Okay, we're from Stockport NHS Foundation Trust, and we're here today to share where we are with our project. We are in our very, very early stages, obviously with some very naive thoughts really. Really interested to hear the ambition and how you've managed to deliver ePMA, but with the very early stages. We just want to share our approach to setting up our project and how we've tackled our baseline. Is it arrow to the left or right or down?
Just press return.
Introduce myself. I'm Helen Bennett. I'm the Assistant Director of IT Programme Management at Stockport, responsible for leading and coordinating major clinical IT projects at the Trust. I'd like to introduce, this is Julie Jorgensen, who's our Clinical IT Project Manager, who's been responsible for delivering a lot of those projects and who is responsible for the nursing element of our ePMA project, and Sarah Campbell, who is our pharmacy project manager for ePMA and is a pharmacist by trade, and Julie is a nurse by trade. Just a bit of background, where are we? We're often confused for being Southport, especially as we're down south. We're actually Stockport. There's no beach in sight of Stockport, and we are 15 miles south of Manchester and 2 miles south of Stockport. We can see the Pennines, not the beach. Who are we? We are a bit like Aintree really, a similar sized trust, a bit slightly smaller, 736 beds, 4,000 staff. We serve a population of Stockport and High Peak all the way up to Buxton, and those are our levels of activity. Our pharmacy dispensed 450,000 items of drugs at a cost of 8 million, so busy, very, very busy DGH. Our project setup and governance. As I say, we're very much at the early stages, but to hopefully deliver a successful project, we have divided the work up into these various groups. We've got baselining, which Sarah and Julie are going to talk about. System configurations for how we build the system and then go on to test it. We've got our technical work stream, which is all about interfacing. We're obviously going to interface with our iSoft PAS for our ADT messaging, and we're hopefully going to integrate it and interface it into our clinical correspondence system, which the doctors use for their electronic discharges. So we're hoping the drugs from the ePMA system will download into the discharges, which will make it easier for the doctors. Clinical engagement, obviously that's a really important work stream, because to me this is not an IT project, this is very much about a clinical change management project, and clinical engagement is a fundamental part of it. Communication is obviously, again, a very, very key element of the project, as is training, and we need to get that right. Benefits realisation, which part of what the baselining is about, is finding where we are and what benefits we're going to deliver, and obviously business continuity planning. As I was saying to somebody at lunch, I think ePMA does make you question how you manage all your electronic systems. With locums, at the moment, they can use, for PACS, somebody else can log on and they can view an image. For ePMA, you've got to get the systems right, that the locums can come in and use the system. So all things about managing a system, what happens when it goes down, is so much more critical about electronic prescribing. So it's really important we get those things right. We set up our project team, and our focus is very much on it being a multidisciplinary group. I chair, Julie and Sarah obviously members. We've got our own project nurse as well. We've got the Assistant Director of Nursing, because again, to me, nursing is greatly, obviously the doctor's very much impacted, but they're used to using computers for electronic ordering and PACS, and sitting down at a computer is a normal way that they are now working through their day. How for nurses, when they're doing their drugs rounds, at the moment they've got the cards at the end of the drugs cards at the end of the beds, and they go round. Well, this is going to be totally different. They've got to log onto a computer to enable them to do the administrations of drugs. So ensuring that we've got nurses tied into the project team and the project board is really important. Obviously, we've got our principal pharmacist and our director of pharmacy involved in the project team, as is our PAS manager, because we're interfacing with PAS, and obviously we've got iSoft, who are our suppliers, are involved in the project team. And we have got our assistant director of IT services, because obviously the technical infrastructure of the project is really important. So very, very much a project team, multidisciplinary team. In terms of the project board, again, multidisciplinary is our fundamental underpinning principle of the project. The project is led by a medical director. That is to get that clinical buy-in. He's been very supportive with a lot of the clinical projects, and he's agreed to take this one forward as well. Got the Director of Information, the lead for the medical business group is on the board. The two consultants from our Phase 1 wards are both on the board, myself, Julie and Susan, and the other people from the project team obviously on the project board. So where are we? It was last November we actually made the decision to go forward with iSoft and got approval for the first phase of the project, which is to go live with 2 pilot wards. The approval is on the basis if it is successful with the 2 pilot wards, there will be an immediate rollout, but approval has only been given for the 2 pilot wards. And last November, Julie arranged a session for suppliers of the drugs carts to come in for the nurses to have a look to see which computer drugs charts they're interested in. We initially we sort of kicked the project off in February, but with a go live now actually. But that got put back a bit because pharmacy had a huge level of maternity leave and so couldn't release a pharmacist to the project. So we're actually formally kicked off the project in September with a go live in February. However, we spent the months between February and September doing a lot of the background work. We had to identify our Phase 1 wards and commence that initial engagement and start our baselining work. Baselining has seemed to take a lot longer than we anticipated. We've had demonstrations on the Phase 1 wards, and in September we started the actual system training, so Sarah and the pharmacists and the technicians within pharmacy can start building the system. On Monday we had our first project board, so we really are underway, and at the moment we are starting, as I say, Sarah's starting to build the system. Hopefully we will complete our baselining exercise and look at our future state planning. And then going forward, we've got to trial the hardware. We want the pilot wards to see which drugs chart trolleys they want to use. We've got to bottom out how we're going to train the doctors and the nurses and the AHPs, because a lot of staff actually interact with a drugs chart who don't actually prescribe or administer. And with fingers crossed, we hope to go live next February. And then we've got the post-go live support. And fingers crossed, we'll then start rolling out across the trust and hopefully to be as ambitious as Aintree and do 4 wards in a month and get through it. Because to run a dual system must be a really hard thing to do. Oh, so yeah, Phase 1. So these are our Phase 1 wards. We've got 2 medical wards. So we've got B4, which is a 16-bed acute medical gastroenterology ward, and E2, which is a 30-bed acute medical elderly ward. To go live with these 2 wards, we need to train, I think it's about just over 40 nurses, all the nurse prescribers, 60 medical staff, and as I said before, all those, the AHPs, the HCAs who actually interact with a chart, look at it, and they need to know how to look at an electronic chart. The reason why we chose these particular wards is we thought we wanted to choose medical wards because obviously if you involve surgical wards you've got to worry about how the patient goes to theatre and how we involve all the surgeons. There's a bigger pool of staff to train if you do actually do surgical wards. That was the other reason we wanted to, and also really the medical specialties are far more interactive with drugs than obviously the surgical specialties. We also wanted to pick 2 different layouts of the wards in terms of, because we wanted to see how we could use the technology within the wards. So B4 is 16-bedded. We've still got old standard Nightingale wards. I'm sure some of the trusts have got them, but we certainly got them. We can see the 14 beds down the centre of the ward and the 2 at the back. So that's one of our pilot wards. And E2, 38-bedded ward, we've got 4 6-bedded bays, 2 5-bedded bays and 4 single rooms. So certainly this ward, a very, very busy ward. So we are being quite ambitious in terms of the wards we're going to go live with, but we feel if we can get it successful in these 2 environments, then hopefully we'll have ironed out a lot of the problems to be able to go forward. I'm now going to hand you over to Sarah and Julie to talk about baselining.
As you might have guessed from the title of the presentation, we are here today to discuss the baselining that we've undertaken and the approach that we've had towards this baselining at Stockport. So, why undertake baseline audits? Firstly, we need to be able to establish our current levels of performance. with regards to both medication issues and errors, as well as any productivity issues within our current workflow. In order to gain a full picture, it has been necessary to gather both qualitative and quantitative measures. And in order to identify any changes or improvements ePMA might have made when it is live, it's important to bear in mind that we will be repeating these exercises once we have gone live. The baselining we've undertaken has included interviews, observations, data collection and process mapping. We're going to talk through each one of these in turn and the activities that we've undertaken. So firstly, the interviews. Speaking as a pharmacist, something I can relate to. We interviewed 9 pharmacists in total. This included the specialist elderly care pharmacist that worked on E2 and the gastro pharmacist that works on B4. And all the pharmacists interviewed had worked on the 2 wards within the last year, so they were familiar with their processes. The questions were relating to their experience of prescribing errors and issues. And speaking as a pharmacist, I know only too well that pharmacists love to tell a story about prescribing issues and errors that they've seen, and they are willing to express their opinion on this. The questions were aimed at getting both qualitative and quantitative answers. As an example of the questions we asked, included such things as what prescription type do we see the most issues or errors with. It sort of leaned towards the discharge prescriptions between the pharmacists, but there wasn't one category that stood out really from them. Of the issues that they saw, how many could cause patient harm if they weren't corrected. This ranged anywhere from 10% up to 80% of the issues that the pharmacists were identifying, so that one varied greatly based on the individual pharmacists. And also on a scale of 1 to 5, how confident are you that the current prescribing process ensures safe prescriptions? And we wanted to get a figure out of this one, but the pharmacists tended to sit on the fence, and I think we averaged at around about a 3. A quote that came from one of the interviews that I find quite interesting was, "At least once a day I do something where I make an intervention and I feel I've made my mark, and it's a feeling that I'm glad I turned up for work today." I think that's quite a nice quote. Other aspects of the interviews were the medics, which I undertook. We interviewed a range of grades of doctors, the consultants working on the pilot wards, as well as their regs, SHOs and F1s and 2s. It also involved discussions with the Trust's medical director, who, as Helen mentioned, is the chair of the project board and is actually an active consultant on one of our pilot wards. The questions were focused on errors and prescribing issues that they had seen made by other doctors. One thing that did come out was that the medics weren't comfortable talking about their own prescribing errors, but if you asked them about errors they'd seen from other people, they were a bit more forthcoming with their information. Questions we asked included, how often do you come across drug charts where the allergy isn't complete? Quite varying answers from that one. Some of them said the allergy's sometimes there but not a reaction. The answers tended to vary. They all hated rewriting drug charts, as you can imagine. The question on how long drug charts took to rewrite proved quite interesting actually. The juniors seemed to say, oh, I can rewrite a chart in probably 10-15 minutes max, even if it's a 3-card exa. The consultants seemed to think that a big chart would take the juniors up to an hour to rewrite. So goodness knows what they think the juniors are getting up to on the wards. Another one was, how confident are you that a person unfamiliar with the drug names could read what is written on a drug chart? And this was at the aim of getting a quantitative figure out of it. And if we look at the quote that came from one interview, you might guess at where the answer tended to lean. So this is from a doctor, remember. Sometimes you can't read the prescription at all, or you can't read doses clearly. That's the biggest issue. I mean, I don't have to give the drugs, but simply understanding what drugs the patient is on and able to understand their history is hard. And that was an SHO that said that. I'll hand over to Julie to discuss the nurse interviews with you.
One of the issues that we were very keen to get over to the nurses was that we wanted them to be honest, and we weren't looking to find fault with what they were personally doing during the drug rounds. And most of them seemed to accept that. Most of them were very open, but they generally felt that there was nothing wrong with the process they've currently got, which, as you can imagine, made us wonder why on earth we're bothering to do all this. When you actually asked them in a lot more detail, then it all came tumbling out. But they were all very, very reluctant to relate to any particular incidents that they'd ever found. And most people generally felt that that was because of the inordinate amount of effort that actually goes into the process from beginning to end by all the people that are involved. So basically anybody who ever touches or looks at a drug chart is a gatekeeper in a very complicated process. And because of that, they felt that the end result was generally very safe, but it was a torturous process to actually get there. Some of our questions were, do you have any concerns or comments about the whole process of drug prescribing and administration? And do you ever have to help your colleagues understand what to administer? And on a scale of 1 to 5, how much do you think the current process makes the best use of everybody's time, where 1 is a lot of time wasted and 5 means that it couldn't possibly be improved? And again, most of the nurses tended to feel that the whole process took forever. I actually went on one drug round observation that took 90 minutes to dispense drugs to 6 patients, which I was astonished at. But they felt that that was a good use of time because that was what they were there to do, and nobody seemed to think that there was any issue with the fact that it took that long, or the perception even that potentially it could be done in any quicker fashion, which I thought was quite an eye-opener. This quote came from a very junior nurse who hadn't been qualified for very long. And she said, they, meaning the doctors, don't write charts at the weekend. I refused to give the drug because there was nowhere to sign. How is anyone meant to work like that? And that was because one of the practices that we've found is very, very common is that when they get to the end and there's no more boxes left to sign in, they just carry on signing in the margin, and to the extent then that you can't even see what anybody's written at all.
We're doing a bit of a double act today, so don't mind us. Right, so the data collection was the next part of our baselining. A form was designed from information gathered in the interviews, and the interviews fed the categories in the form, really. We aimed at gathering raw data on prescription interventions that pharmacists were making. The form was designed in conjunction with iSoft, and data was collected for 2 weeks on the 2 pilot wards. The second ward is planned for the start of November. We've only undertaken 1 ward so far. The data recorded included the document type, was it a discharge prescription, an inpatient or outpatient script? At what point was this error identified? Was it during clinically check-in, administrating? Was it flagged for review? The grade of the prescriber that made the error? The time taken to rectify from the pharmacist's point of view? The issues that were with the prescription? Was it a prescribing error, or was it, you'll see the categories on the next slide. The outcome, what happened, what did the pharmacist do to rectify it? And the possible impact that error could have had it not been identified. There was quite a few categories we looked at, and it wasn't just prescribing errors. It was anything from prescribing the drug from a wrong patient, to the drug not being prescribed, to the chart not being available on the ward. You can see the intervention and potential impact fields down there as well. Just looking at what impact it could have had on the patient, was it not identified? Back to Julie.
Jumping around. So similarly to the pharmacists, we designed a form for data collection that the nurses were supposed to collect during the drug administration rounds, and we took that from the comments that they made during the interviews, plus the observations that we made ourselves during drug rounds. And the data collection for that actually only started last Monday, so it isn't complete at the moment. You might be able to see some of the issues from the form there. They range from the Cardex not being available at all to there being more than 1 chart, and sometimes they can only find 1 chart, but it might say 2 of 2 and they can't find 1 of 2. to being totally illegible, and also then some of the impacts related to what that issue caused, how long it actually takes them to find the drug chart. Some of the nurses seem to think it's not a problem because they know where to go and look for it. The fact that it takes them 5 minutes to go and get it and come back to the patient, they just seem to accept as normal. So we're hoping that we're going to be able to show them that it can actually be a lot more efficient. And we're hoping to pull all this data together in a couple of weeks' time. Actually observing the medication drug rounds, as I've already mentioned, was actually quite an eye-opener, because we didn't realise how much time all of these things were taking. Now, it is a long time since I've done drug administration myself on a ward, but things do seem to have changed, and not necessarily for the better. We do need a lot of standardisation as well. Some of the wards have gradually tried to bring in changes and improvements in their own area, but then that's completely different in a different area. So nurses who work from across wards and move from one ward to another are finding that maybe it's not consistent. So we're going to do some work around that. We observed times of all the different times of drug rounds throughout the day over a period of several days, and that included weekends. And we also checked to see how long everything took. One of the things that we observed was that even though there were only 8 patients in one particular drug round, there were 5 post-it notes stuck onto different charts, and all these charts then were collected up so that the nurses could pass those messages on to the various people at the end of the drug round, whether that was to say that they'd run out of a drug and they needed to order it, or whether to ask a doctor to prescribe something different that wasn't right. This was a drug round at 8 o'clock in the morning, and one of the medications was totally illegible. And then we had to wait until the doctor arrived on duty at 9 o'clock before the patient could be given that medicine after it had already been rewritten on the chart. The ward round observations have only recently started. Our new IT nurse only came into post 2 weeks ago, so she's very new, but already she's making big inroads into some of the preparation that we need to do for this. And she's attending consultant ward rounds to observe what the interaction of the medication chart is. And when she came back from one consultant ward round on Monday, again, the same thing is coming up time after time. Illegibility, the charts are missing and no one can find them. And some of the charts are just downright scruffy because they're made out of cardboard. They're generally kept in a ring binder. And on one of the wards, it's on the end of the patient's bed, and on the other ward, E2, it's in a sort of a box that holds 6 or 5 folders in the bay, on a little desk in the bay with all the patients, and they're constantly being taken out in and out of that folder, and some of them are torn. The rings don't work anymore because the holes are all torn, and generally everything's a mess. And also the cards just seem to get passed from one person to another. If there was 4 people on the ward round, everybody had it at some point, and it was going backwards and forwards.
Me again. This is the last time I'll speak, I promise. The process mapping was another aspect of our baselining. As you might guess from the title, it's an exercise in defining and mapping out our current medicines management process and how it works. A session was held involving a multidisciplinary team, representatives of pharmacy, nursing and medicine, and we discussed the patient journey and the relevant medicines management processes that interacted within that patient journey from admission through to discharge. We looked at what happens when the patient's admitted to the ward. Do the drugs come with them? Does the drug chart come with them? How often doesn't it happen? And similar situations to that throughout the patient's stay. From that, a document was produced detailing the full patient journey. It's quite a vast document. We reviewed that and a final version is being produced. Going forward, we need to map out essentially our current and future states. This is an example of the swim lanes that will be produced. This is an example from another hospital, but essentially this is what we will be mapping out as to how we currently work and how we will be working with the system. And I'll hand over to Julie for the last time.
We've nearly finished. Okay. A couple of other things that we're intending to do as part of our baselining is a review of the medication incident reports from the 2 wards. Sarah's been looking into those, and there are actually very few of them. And that could be interpreted as nobody's reporting the incidents that are actually happening. But over the last few years in our organisation, we have done an awful lot of work on incident reporting, and we are fairly confident that we've got a very high incidence of reporting. So we're hoping that that will actually be useful information. The other thing that we're going to try to look at is the hospital at night eye bleep system, which I'm sure quite a lot of hospitals around, I know a lot of hospitals around the UK are using, to look at the work that's actually assigned out of hours. We're hoping that although a lot of that won't necessarily change, the jobs will still be there, it might make the jobs easier to do. We have a lot of warfarin that isn't prescribed at the right time of day. A lot of patients have to wait quite a lengthy time for different medications to be written up, particularly analgesia. And we're hoping that if they can do that remotely, it might speed up the process. Although we are very mindful of the fact that we don't want doctors prescribing when they haven't bothered to go and see the patient on the ward, so there are some issues with that. Some of the issues that we found along the way, I suppose not surprisingly, it's been very hard for Sarah to be able to get time with the doctors. They won't stand still, although they're very supportive of it, and a lot of them think ePMA is the best way to go and they're looking forward to using it. We can't get them to stand still long enough to talk to them. Consultants and junior staff, you really do need to make appointments with them and try to get support from the consultants to make sure that people do stick to the appointments. And the first day of using the pharmacist data collection forms proved to be quite confusing, and in retrospect perhaps we should have tried it first and then maybe see did it work and before we actually went ahead with a full collection. And again, we haven't done that with the nurse drug observation forms either, so we're not quite sure whether we've got that right. We'll probably know by the end of the week. I think I felt that some of the interview questions didn't necessarily draw out some of the issues. We tried to ask the questions as open-ended as we possibly could, but I still think that there are some issues going on in there that people weren't really prompted to tell us. So we may need to do a little bit more digging there. And we also thought we could have learned a bit more from the process mapping sessions that we held. The staff that attended didn't really know what was going to happen in that session, and it might have been better if we told them the questions beforehand so that they knew what to expect and they could have prepared themselves a little better. And although we did include multidisciplinary staff, we don't really think that we had enough people there, and it would have been better if we'd have had more people. So the next steps, which we are looking forward to doing if we don't resign tomorrow, is to complete the baselining. Hopefully we're on the end of that now. We also need to complete an IT skills assessment, and that's largely for the ward nurses. Helen and I have been instrumental in introducing a lot of clinical systems over the last few years, and we were hopeful that that was the preparatory phase for hitting them with ePMA. Although, as you've probably experienced yourself, there are people who are extremely good at avoiding what we wanted them to do in the first place. So although they all should be doing real-time ADT, and they should be using the pathology results reporting system, and they should be using electronic ordering, some of them have been very good at avoiding all of that, or only doing a little tiny part of it. So at the moment we're in the process of doing questionnaires with the nurses and also doing face-to-face interviews to see how they really feel about their own IT skills, because we can't go into electronic drug administration if they can't switch the computer on. And we do think we've probably got some people who are still at that stage. System configuration is largely Sarah's baby, so she's about to embark on working out how to do all of that, and then we'll be doing system testing together. Ward hardware setup is probably actually one of the relatively easy things about it, apart from we are at the moment in the middle of a complete network reconfiguration and refresh of all our entire network and wireless system, and we're hoping that that will make us completely resilient by the end of the year. And then it will be go live, and all the way running through all of this is communication, because unless every single person in our hospital knows what's going on and knows what their place is in all of this, it won't work. So thank you for listening.